quickly. We've had the pleasure for meeting with us. We had a lovely dinner. She's been spending time with fellows. She's going to be more today. We really appreciate you coming up and joining us. Fatima did her medical school and internal medicine training at Harvard. She also received a master's in public health there, and then moved to Stanford for her cardiovascular fellowship, where she's continued to be on faculty and risen rapidly through the ranks. She's section head for preventive cardiology. She's a well-funded and active research scientist in the space around prevention, in particular looking at really new, rapidly evolving technologies. She's going to talk about that today. We really appreciate you coming up and joining us.
Thank you so much. Thank you, Greg. Just doing a quick tech check. It's always good to start the morning like that. Everything good, Jennifer? Everybody online?
We had comments already that everything was working fine. Looks great.
Wonderful. Well, thank you all for being here so early. This is even earlier than Stanford Grand Rounds time, so I'll have to report back, and to see so many familiar faces and friends here in person today. So today I wanted to talk a little bit about artificial intelligence for opportunistic screening of cardiovascular disease. These are my disclosures, which are not relevant for this talk. And this is an outline of what I hope we can cover today. It's always good to center our research around a patient case. So I'll start with that, discuss coronary artery calcium and its role in cardiovascular risk assessment, opportunistic screening, and then the potential future of AI as we think about caring for our patients. So let's start with a patient. I said clinically I practice preventive cardiology, and I had this patient referred to me, Mr. ST. That's actually his initials, even though it seems appropriate for cardiology. But he was seen at a community health center, and he underwent a lung cancer screening CT for a nodule. And incidentally, he was noted to have severe calcification extensively across his 3 arteries. This was commented and actually made it down to the impression of the radiology report. So he was referred to Stanford for preventive cardiology clinic. I am not a radiologist, and like my friends here in the audience, and I don't read CTs, but I could tell it was a lot of calcium. And his past medical history was relevant for pancreatitis in the setting of heavy alcohol use, prediabetes, hypertension, and he had a right lower leg amputation. A very challenging social history. And he came to us and said, "What should I do now, doctor?" So we'll get back to him at the end of the case. So I love cardiology because cardiology is around 80% preventable, especially cardiovascular events related to atherosclerosis and vascular disease. And ideally, we focus on primordial prevention, where we prevent the risk factors developing in the first place. A lot of what we do in primary care is primary prevention, where we focus on reducing cardiovascular disease risk factors to prevent an event from happening. And then something that in our preventive cardiology clinic, we have coined prevention 1.5, which is identification of people with subclinical atherosclerosis, and again, starting preventive therapies more intensively. And that's really where coronary artery calcium falls. And then a lot of our tertiary care centers really focus on secondary prevention, patients that have events, and preventing that risk from progressing. So I know almost everyone's familiar with coronary artery calcium, and there's a very useful tool that can measure the amount of calcified plaque in the arteries, and it's quantified in Agatston units, and it sums up the area and the density of coronary artery calcium. And this is usually obtained for a specialized CT scan that's called a gated scan that is timed to the beating of the heart. And we have shown many, many studies, I'll show you some data, that this really predicts cardiovascular events in a nice graded fashion. And I wonder here, is this covered by insurance companies? Do you guys, or do patients have to pay out of pocket? Okay. So at our institution, it is not covered by insurance companies, and it is recorded, so I'll keep it positive, but it actually, the price has gone up. So the out-of-pocket cost is around $325 at our institution. And the reason for this, again, traditionally, is because there have been no cardiovascular outcomes trials that have shown that knowing about coronary calcium as a screening test reduces events. But despite that, there's really compelling epidemiological evidence that CAC predicts cardiovascular events really across all groups in a very graded pattern. And a CAC of 0 can essentially de-risk you. And that's a lot of our patients love getting a CAC scan so they don't have to take statins. I would say that's the biggest motivation. But as your calcium score goes up, you really start approaching rates of secondary prevention in terms of events. And I clinically treat, and I'll look to see what Eugene does, to treat patients with a CAC score over 300, basically exactly how I would treat somebody with established coronary disease, instead of very intensive lipid goals, aspirin. And again, more recent work has shown that patients with CAC scores over 1,000 are very high risk, similar to secondary prevention patients. And a lot of our work really focuses around health equity and diversity. And again, data from MESA has shown that the value of CAC really extends across all racial and ethnic groups, very predictive. And that makes sense because it is really biology. It's in the causal pathway for coronary disease. So what do the guidelines say? So these are the most recent prevention guidelines. I know there's some cooking more now, but basically what they say that you can see, that if your risk is uncertain, so again, this is based on the pool cohort equation, that you can consider a CAC test sort of like as a tiebreaker, especially for patients that are indeterminate risk or maybe have some risk enhancing factors and their 10-year predicted risk is very low. You may consider this to help you decide, does it make sense to start a statin therapy? And again, for CAC over 100 or greater than 75th percentile for age and sex, the guidelines recommend initiating a statin therapy. And again, here just a little bit bigger. For intermediate or borderline risk patients, consider a calcium score. And again, if it's greater than 100, it's pretty definitive that you benefit from statin therapy with a level of evidence of 2A. And again, B, because there's really no randomized studies, but this is based on very strong epidemiological data. And again, I think a lot of the work around calcium has focused around reclassifying individuals. So not only who should be on statins, but potentially who can be off statins, especially if there's another reason they don't want to be it for patient preferences, and that could really reclassify individuals. And my good friend and colleague, Karim Nasir, has done a lot of work around this. There's a lot of the Twitter following around the power of zero, how CAC of zero can essentially de-risk patients. There are some caveats, which is outside of the scope of this presentation, but where, this is just calcified plaque, there could be soft plaque. So obviously that's missing those individuals. But again, in this study, it shows that essentially if you have a calcium score of zero, that in those cases, you could avoid statins. And again, a lot of our patients have expressed that interest. So what do you do if you have calcium? And this is observational data from the Walter Reed Medical Center in patients without pre-existing CAD who had CAC testing. And you can see that individuals with CAC scores that are even very high, over 400, if you started statin therapy, that could very effectively mitigate that risk from that elevated calcium score. So again, very actionable information. So one of the reasons we do a lot of our tests in medicine is to improve our shared decision-making with our patients. And there's been a couple of clever studies that have actually done this, and this is the Eisner study and the CoreCal study that have shown really an impact on improved shared decision-making when you have a calcium test to really promote healthy changes and better cardiovascular risk factor control, and very importantly, statin adherence for patients with elevated calcium. But again, importantly, also can de-risk people. And this is, again, work showing that calcium scores, the actual number, not just the presence of calcium, can change prescribing patterns. And we see that patients with very high CAC scores are much more likely to have statin therapy, but also higher intensity statin therapy. Unrelated to calcium, but related to subclinical atherosclerosis, this study, the VIVISA study that conducted in Sweden, showed that if we show patients visual images of their carotid plaque, that can actually motivate behavior changes, increase statin prescription rates, and really control cardiovascular risk factors at 1 year. And again, with helping the patients understand the value of medical therapy. So with all that background, it seems like great, CAC testing is very helpful for primary prevention, can potentially help us really refine risk assessment for our patients. So why don't we do it? So as I suggested, we don't use CAC testing because this is most of the time, at least where I practice and in many places, not covered by insurance plans, especially for individuals of lower risk. And there's a lot of data showing that minoritized racial and ethnic groups are less likely to see me in preventive cardiology clinic or Eugene, and therefore may be less likely to have this risk refining test, and therefore less likely to have CAC testing. And in fact, this was shown by my colleague, Dr. Kim Williams, and this is data from Chicago hospitals that showed even the availability of CAC testing is limited based on where you live, just geographically. So there's fewer CAC tests in areas that have low household incomes, higher poverty, and higher proportion of African Americans. So what if we removed costs from the equation? Will that make everybody get a CAC scan? And it turns out in this study, and again, this was done in Ohio's health system, where they just made CAC testing free. And I believe they're actually still doing this. They initially made it low cost. You can see here in the red. And when they made it low cost, it was it was helpful, but again, it's actually the low cost is in blue. You had some increase in the use of testing. But when they made it free, you can see a lot more uptake in testing per month. And again, that required individuals to have at least one cardiovascular risk factor. And this increased the diversity of who was getting CAC testing, more women, more African Americans, and people living in zip codes with lower incomes. So this really led to our question, our research idea that, again, as clinicians, we often would bring up an unrelated scan if somebody had a CT scan just to see, do you have calcium? Can that help us decide about therapies? And that's really the idea of opportunistic imaging. So there's imaging that we know our patients have sitting in the PACS data that has been done for other reasons. Can we use that to help us identify cardiovascular disease? And this happens all the time in radiology imaging. For example, you can look at a bone density and abdominal CT for osteoporosis. And this is a little bit different for incidental findings because we actually want to find this. And the role of artificial intelligence here is really a tool to help us screen large volumes of these CT scans very efficiently. Although my colleague Domenico may say it's not so efficient, right? We'll talk about that because he has been working with this on us for many years. And there are about 1 million CAC tests done each year that are, again, gated, dedicated, but there are many more tests that are done for non-gated scans, again, not gated to the beating of the heart. And there's around 19 million of these tests done annually in the United States. And again, a lot of work, qualitative work, has shown that the CAC on these scans also predicts events in epidemiological studies. And we know there are a lot of these tests are happening in our emergency room, in different clinics, follow-up for malignancies, et cetera. So this is where the partnership happened with our preventive cardiology group and computer science and data science team. So we had this wonderful group of master's students who had developed an algorithm, and they now started a company called Bunker Hill, where they were able to very accurately quantify the amount of calcium in non-gated chest CT scans through a gold standard of ground truth of gated CT scans with very high sensitivity, very high positive predictive value for a CAC of 0. And again, this technology, since our partnership, has continued to get better. So this is really a way to scale the review of thousands and hundreds of thousands of CT scans to identify the presence of calcium. We looked at this data at Stanford. This is work led by one of our amazing residents who will now be joining fellowship at Johns Hopkins University, Allison Peng, showing that when we look at the DL, which we're calling deep learning calcium or DL-CAC, from the non-gated CT scans, it actually was highly predictive, again, of cardiovascular events. And the population who underwent these scans was extremely diverse, more than 50% women, 18% Asian, 13% Hispanic. And of those scans, again, these were people without ASCVD history, about 50% had calcium. And this was very, very predictive of ASCVD events and mortality. And of course, you may ask, well, why are they having the scan in the first place? There's competing risks. And it turns out that even in people who are undergoing CTs for lung cancer screening, cardiovascular disease still remains the leading cause of death. So of course we have to consider that, but the public health opportunities are tremendous here. Allison has now gone on to look more closely about the difference in the demographics and the clinical factors of who's getting a non-gated chest CT in our health system versus those that are getting gated scans. And again, not surprisingly, those getting non-gated chest CTs tend to be older, tend to have more comorbidities, are more often women from diverse backgrounds. Actually, we found that a lot of them had needed interpreters, so non-English language preferred, and had Medicaid insurance. So our clinically actionable question is, can we use this incidental or opportunistic calcium quantified through artificial intelligence algorithm to guide preventive therapies? And this is really the basis of the Notify-1 study that was led by my colleague, Dr. Alex Sandu at Stanford. So a very small, pragmatic quality improvement study where we identified patients within our Stanford healthcare system who had no history of ASCVD, had calcium present on a chest CT, were not on a statin, and had their care within our healthcare system, which is really, we'll discuss, a big drop-off. I did not know he would be here today, but my great friend and colleague, Domenico Mastrodigasta, who is now on your faculty, actually manually reviewed every single scan because he's a board certified radiologist to confirm the presence of calcium, because our IRB and many were very concerned that is this artificial intelligence algorithm actually doing what it's supposed to do, especially when we're reaching out to patients. And not only did he do that, he also helped us identify what's the best picture that we could show our patients of the presence of calcium to motivate behavior change. So, and he still has a lot of work to do, but we're very grateful to him for all the work he's been doing here. And then we divided the cohort into a notification arm where we notified the patient and the clinician of the presence of calcium, and then the usual care arm with a delayed notification of the usual care arm. And again, the intervention here, which I'll show you, is a very simple one. It's just a personalized picture of the individual's elongated chest CT with a big red circle. Just say, this is not good. This is your arteries. This is calcium. We first notified the primary care physician and said, this is your patient's CT scan is incidental finding. We recommend considering discussion around statin therapy. Initiation of statins is the primary outcome. And then 2 weeks later, there was no objection by the primary care doctor saying, there's something going on with this patient. They really shouldn't be notified. We notified the patient. And this is just an example of what the clinician notifications look like. And this was done through My Health on Epic. Again, the nice red circle showing this shouldn't be there. There's a presence of calcium. And this was verified by a board certified radiologist right over there. And you should consider having a discussion based on practice guidelines. Again, we did not prescribe the statin. We just suggested the discussion. We did a similar with our patients. And again, when we did this study, we thought this was a pretty effective notification, but I'll tell you later what our patients said. I said patients have an increased risk of having a heart attack compared to those who don't have calcium. Talk to your doctor about thinking about starting statins. So what did we find? We found, again, that both arms were well matched in terms of characteristics. Again, most of them were older, about half women. Very few had prior cardiology encounters, and most of the CT scans were really for pulmonary findings, right? To follow up on pulmonary nodules, lung cancer screening, follow up on early stage cancers, because we excluded anybody with advanced malignancies. But you can see a lot of these CT scans were actually very old. They were done they were in some cases years prior to the notification. And many of them had very high calcium scores, about a quarter of them over 100 Agatston units, DLCAC. And if you actually look at the radiology reports, most of our reports actually mention calcium. They're and again, you could see that the majority, again, noted that they had some calcium, whereas mild, moderate, or severe, but rarely was that finding brought down to the impression of their radiology report. And if you estimated the patients in the studies, their risk of cardiovascular disease based on the pool cohort equation, again, many of them already met criteria to be on statins anyways, but none of these patients were on statins. So what did we find? We found that at 6 months, our primary outcome, which was statin initiation rates, was 6.9% in the usual care arm that was not notified. And then notification arm, we found a statin initiation rate of 51%, which is a very huge effect size for a relatively low touch intervention. There was also halo effects around other cardiovascular risk factors, which improvement in blood pressure control, hemoglobin A1C. And when we looked at subgroup analysis, really was no heterogeneity within the specific criteria, including baseline LDL and patient characteristics, or even time from the CT scan. But this is something that we are looking at in more detail, is like what happened next. Now, where patients having more encounters, again, we can see that they were more likely to follow up with their primary care doctor to have these discussions. A lot of these patients were referred to cardiology. A lot of these patients went on to have gated CT scans or stress tests. So these kind of unintended consequences of these studies need to be also considered. And this is our patient who's part of our group. He joins all our meetings. We have him even writing papers. So this is Doug. Doug is a retired plant breeder from Fresno, California, who many years ago had a CT scan to follow for a history of thyroid cancer about 5 years ago. And then at some point, he sees a cardiologist for an unrelated reason and is like, you have a lot of coronary calcium. Did you know that from that CT scan 5 years ago? And Doug was very upset that nobody had told him about this, and has joined our research group to really help us frame the patient notifications. And he's very excited to be part of this group because he wants technology to help patients understand if they are at risk for a disease earlier on. But as effective as these interventions were, a lot of our patients that were notified in discussions with them were very stressed. One of our patients told us, I was at Costco and I got this My Health message and I nearly dropped dead from the scary notification. So I think we have to balance the efficacy of the intervention with the stress that we may be causing patients. And again, a lot of them are grateful and they said this really felt empowering. Like now I can just, take control of my health and make different health decisions. But we have to balance that with the distress that these kind of notifications can have. And we have an ongoing study partnering with an evaluation science units of implementation scientists to understand all of the patient's perspective from being notified, but also ask a different group of patients with chest CTs how they feel about using artificial intelligence to look at their existing imaging studies. How acceptable is it? How can we balance the patient acceptability versus the efficacy of the intervention? Who should be delivering the notification? Should it be us as investigators or should it be their own doctors? We have a series of studies ongoing following up the Notify 1 studies. We have a Notify Extend, which is ongoing, again, talking about statin persistence a year after notification. And we're just starting to look at this data, but again, it looks like the rates are very, very similar as they were at 6 months. Another project that Domenico was very involved with, which is the Notify Picture. So our hope is that we could embed this into current active radiology workflows, where as the scan is happening, we can notify the patients more real time. And we are doing that right now in a pretty complicated process, which involves a workflow from our research IT, our PACS radiology system, and our research databases, where again, as people are having these scans in real time, we are identifying those without ASCVD, not on statins, and even some that have ASCVD and are not on statins of the same process, and trying to see what kind of effect size we get here. There's been a lot of interest in, can we use this information to also help patients with secondary prevention? Now, a lot of our patients that have known cardiovascular disease are not on statins. The data is around 50% of those patients. Again, they should know they have atherosclerotic cardiovascular disease because they have a diagnosis, but maybe they just don't quite understand the benefits of statin or lipid lowering therapy. So we have an ongoing quality improvement project about, again, showing them the picture of the coronary artery calcium in their arteries. And in this study, we're actually going to test how much does the picture matter? Because for us, we think the picture is so valuable. But our patient representative said, you could just literally put a picture of any heart. It would make no difference to me. So I think we're going to test that in this study. And again, we assume that for these patients that the presence of calcium will be very high because they obviously have atherosclerotic cardiovascular disease. And instead of just statin therapy, the primary outcome here is just any lipid lowering therapy. And again, secondary endpoints of LDL goals. We've been working with the Kaiser Health System about thinking more about how we notify patients and how we incorporate in the health system. And we are launching a pragmatic study with them, trying to change the different parts of the notification process and seeing which ones can be most helpful to balance acceptability and efficacy. And we just submitted an RCT study to PCORI, again, looking at does this actually change events and outcomes using a lung cancer screening population, because opportunistic screening for for ASCVD in lung cancer CTs makes a lot of sense. There's a lot of shared risk factors. And again, it is normal actually to already comment on it, but we want to take it to the next step and be able to guide therapies. So moving on for using AI for other opportunistic cardiovascular disease screening. So we talked about the calcium scoring. So gated CT scans, there's about 1 million of those done a year. We talked about non-gated CT scans, chest CT scans. But even more common than that are abdominal CT scans. So when you present to the emergency room with abdominal complaints, more often than not, you're going to get abdominal imaging. So our group has become also very interested in looking at abdominal CT scans to see if we can understand cardiovascular risk. And again, there's a lot of information in these scans beyond calcium. And I know there's been a lot more interest in just hepatic liver fat, visceral adiposity, how we can use that to predict cardiovascular risk. And this is work being led by our colleague Akshay Chaudhry at Stanford Artificial Intelligence Center. we're cardiologists. We were like, okay, cardiovascular disease prediction is the most important. But Akshay has challenged us to say, why don't we predict more than one thing? Again, these scans have a lot of information. So he has developed and his team systems to predict the 5-year incidence of many diseases. Again, ischemic heart disease just being one of them. And so far, the performance of these risk prediction models has been really excellent, as shown here, and can really predict cardiovascular and other events using the existing imaging data that, again, has been done for other reasons. Our group has also been interested in how do we identify early aortic stenosis with CT scans. And this is data from MESA showing that people who had a CT scan and had some calcium already shown in the aortic valve, just in these CT scans, many of them years later were to develop aortic stenosis. So can you diagnose aortic stenosis earlier before patients become symptomatic with heart failure and chest pain and syncope? And of course, there's been many studies from different groups showing the value of AI for detecting diseases like cardiac amyloidosis. And again, echo studies that are done for other reasons. We know that many of our patients are underdiagnosed, especially those from diverse backgrounds, until they present with advanced disease. There's been studies showing the value of echo in diagnosing these, but also just in simpler tools like ECGs that we know are done very frequently. And even X-rays, there's been some studies that, again, the more common the study, the more opportunity, but again, you trade off sensitivity and specificity. So let's go back to our patient, Mr. ST. So we spent a lot of time in clinic where I pulled up his non-gated, actually low-dose radiation CT scan that he had for the lung cancer screening. And we reviewed the imaging. It had significant atherosclerotic plaque that he could see, he could identify. He's like, that's in my artery? I'm like, yep. He was a smoker, so we counseled him extensively on smoking cessation. And to this date, this is a patient that I've had since I was a cardiology fellow, actually. He's stopped smoking, doing very well. I started him on a high-intensity statin and aspirin 81 milligrams, and his last LDL was 50. I was very happy to see that. And then he had, again, halo effects around other cardiovascular risk factors, his diet, his health behaviors. And again, this is somebody who would have otherwise not been brought into our care. So in summary, CAC can substantially improve ASCVD risk assessment. It can really help us guide statin decisions. It's a very useful tool, but we really know that it's not available to everybody. And again, you're getting additional imaging, and that may require, in most places, an out-of-pocket cost. Incidental calcium can really be quantified through these deep learning algorithms in non-gated, non-specialized CT scans. And again, our group works with a specific algorithm, but there are many other algorithms that can do this. And I really think that the innovation lies in the application of these algorithms to patient care, not so much in just the algorithm itself. When we notify patients and their clinicians, as we saw in the Notify 1 study, it can drastically improve statin rates, and these effects appear to be sustained. And we're now testing different iterations of the types of patients, the types of notifications that we do to see if we see a similar effect size. Artificial intelligence is very promising as a tool for cardiovascular screening, but again, we need to know what to do with these patients once they're identified. How are we going to care for them in our healthcare system? And that's really the work that we need to do moving forward. How does this affect clinical outcomes, clinical care? We're going to have a lot of unintended additional testing. And how does this affect health equity? So I would like to just thank our incidental coronary calcium team that actually has grown even since this picture. Domenico here. My research group, the Heart Lab, which is, again, wonderful students, very interested in how do we improve the care of all of our patients. Our Stanford Preventive Cardiology section that I'm honored to lead. Our funding sources. And thank you so much for your attention.
Thank you very much.
Thank you.
That was fantastic. Yeah, we have questions.
That was just fantastic job. At the beginning, I was very excited about the technology and AI. As the talk went by, I kind of feel like this is like human behavior. We try to, so then the patients, they met the criteria to be on statin, right? So it's kind of interesting. It's not really about the technology, it's about implementation and communication with patients. Can you kind of comment on that? Because it's not really, the AI is just helping us convince our patients to do what that they should be doing.
not only just our patients, but also our physicians, right? I mean, I think that, I agree. And I initially, we were all like, oh, the AI. And our IRB came back and said, why do you need this technology? You just look at it. Yes, Domenico can just look at the scans, but it's just at the scale of that, right? So I think the AI is a tool to screen rapidly. And it is, cool, patients like it, it's like a good term, but I agree, I don't think that's the innovation. And especially where we are in Silicon Valley, there's a lot of innovation around technology getting better and better. Because even the performance of this technology depends on the type of CT scan, right? So there's a lot of technical pieces of this that do matter. There's a technical piece, but the much more important part is the implementation piece.
Right, I mean, I think you're right. When I'm on service, when they're presenting patients, it's often that patients have a CT done in the emergency room. I agree that the data is always there. It's just it rarely makes it into the impression. So I usually ask the residents to tell me if there's calcifications because it moves their pretest probability much higher.
Yeah, and also can help you decide what kind of tests to do next, right? There's a lot of calcium you may not want to do a dedicated CT to look for coronary disease.
We have a question from one of our viewers. Dr. Thompson asks, can AI evaluate from chest X-ray, not CT?
So there are a lot of studies around AI for using chest X-rays, not around coronary calcium, but again, we don't know how, but if I predict diabetes, there was a New England Journal of Medicine paper about that. Very good performance for predicting diabetes. And again, I'm not sure what went into that deep learning algorithm, but it is there.
And Dr. Dean's asking, can you comment on the application of your initiative to indigenous populations, which are at the highest risk of developing cardiovascular disease?
Yeah, and I think it depends on the health system. So a lot of what we're doing now in our subsequent set of studies, that we have partnerships with other health systems, and that's the goal of one of our grants with MedStar, Mayo Clinic, and actually at the VA as well, just to see can we apply it there. But yes, for this kind of technology, they have to have the CT scan in the first place. And the question is, and this was an issue that raised by our IRB, once we identify the patients, who's going to see these patients? And so we need to have that there. And ideally, and I think I was telling you this yesterday, Fareed, I would think there should be a care pathway, like cardiometabolic care pathway that is independent of having a primary care doctor in the system. We already have so many other things to do. They don't need to see preventive cardiologists. A lot of these things are algorithmic, right? You lower your LDL, you treat your hypertension, you make sure your hemoglobin A1C is controlled.
So I have a question and we'll get some more. So I think if your Corey gets funded, that's going to answer this actually last, but I wanted to ask, how do you think about the amount of calcium and the distribution of calcium? So you're sort of getting a binary output from your tool, but this is what the approach does with CAC. Do you think there's more information, or have you tried to get more information out to help you think about risk stratifying, choosing different treatment options?
Yeah, absolutely. And I should say that this algorithm gives you a quantitative amount of calcium. So it's not just yes or no. For the purposes of the study, it's binary. And again, the higher the calcium, the higher the risk. But the location matters. There's just an editorial about this. So if it has left main calcification, but again, we could visually see it, right? Domenico could put it in this circle. We're not using that because there's a degree of complexity that comes with doing that kind of approach and validation of the algorithm that is not FDA approved to do that.
Do you think there's a use in the future, or do you think this is really just about, we have a hammer, it's called statins, let's get things with it?
Yeah, I think there's certainly a use, and the Bunker Hill company keeps making the algorithm better. So for example, now this is just for scans that don't have contrast. We know that almost every scan that we order has contrast, CT, abdomen, pelvis, the whole thing. Because the contrast can create artifact and create again all these things. So it's going to get better and better. So yes, I think the tool can get better, but it's our job as the clinicians and the researchers to say, what question do we want answered? Do we think that's a valuable use of a screening test? Probably not, because you have CCTAs that can do that much better for patients who are much higher risk.
Great.
Thank you. That was a great talk. I've been around long enough that I've sort of seen sort of things that have been rolled out in terms of identifying high-risk populations. I always remember back about 15 years ago, there was a study, I think Eric Copel was one of the authors at the time where genetic screening was first coming out, and they did a study where they identified people who were at so-called higher risk based on genetics, and then they wanted to see, well, what was the impact on the patients? What was the, downstream effects in terms of additional sort of investigations, and then, did it lead to sort of anything? And so, and that was sort of a first sort of intervention. The good news was patients weren't at all there was very little anxiety about them being identified as being at some full increased risk. The bad news was nothing ever happened to it. They didn't change their lifestyle. They didn't lead to any additional tests. And so it sort of put a damper on the enthusiasm. I looked at your results and went from like 6% utilization or 6.9 or something in terms of statins up to over 50. And I said, that's an amazing sort of impact. And what do you think it is different about what you are doing or the information you're sharing? And is there a way to sort of focus on that to sort of get the impact even higher?
Great question. So that was a very large effect size that, everybody was surprised that a lot of studies around statins have not shown such a large effect size. It was a carefully curated population. That's what we're trying to change in our subsequent studies. So these are all patients that had primary care within the healthcare system. So again, and we did this because this was a quality improvement study, so that we could ascertain the outcome passively without having to call anybody. I think that something very about visualizing your own plaque in people who were very low, in their minds, they were low risk, was very visceral, and that probably led to those discussions. But I actually don't know, and I don't think the effect size will be as large once we expand and expand the inclusion criteria.
Yeah, so the next question we'll take from Dr. Lindbergh, who I think can unmute himself. Just go ahead and ask.
Excellent talk. The question I have is, how frequently does the coronary calcium identify patients who would not merit a statin based on the 2013 ASCVD risk score? And if my guess is that it's not very often, and in that case, how about a Starbucks gift card to people who just run the risk score?
Oh, you're saying, okay, so the question is, can we use this kind of opportunistic imaging and DL-CAC to de-risk individuals?
No, just the opposite, saying if you're finding people who are at risk and should be on a statin, if you look at their risk score by traditional methods, how many of those people should have been on a statin anyway and just were missed?
Yeah, so they did this, and that's what the CoreCal and the Eisner studies did, right? And it turns out like that, yes, a lot of them, and it would say that they're not being missed. A lot of them are reclassified if you actually get a gated chest CT. It turns out that's just not as an effective way to motivate behavior. It's like the pool cohort equations, saying what percent you are 10-year risk. It doesn't motivate a lot of behavior as compared to visualizing calcium, which is just obviously further along the causal pathway for coronary disease. So they've tried that, saying, and again, that's a really good point. You could argue, and we actually did with our IRB, these patients should be on statins anyways, if we just use the pool cohort equation. So there's really they're not even in between intermediate risk here. But what happens is that they still are not, because for a variety of reasons, patients in primary prevention, the rates of statin use, even when they're high risk, have plateaued around 30%.
Oh, thank you.
Awesome, that's a great presentation. So we actually are doing a CORE study actually now with non-gated CT scans for lung cancer screening. And interestingly, one of the patients recently, were screening a patient, said to our research staff, well, what if my calcium score is really high? Don't you have an ethical obligation, to tell us what to do? And some of these patients potentially being enrolled in sort of the observational arm of the non-treatment arm. So how did you manage that? And the thing that I was thinking about is that you started like 4,000 patients and you ended up with like less than 200. So what were the reasons why you had so much drop off in the study? Because I feel like these are the kind of considerations that may be causing the drop off.
Right. So for people we ultimately randomized, we actually did a delayed notification of everybody. So we've notified everybody on the study. Now, the inclusion criteria, because this was a very carefully selected population, they couldn't have advanced malignancy, dementia. We used a lot of chart review, which again, we're trying to not do that for our subsequent set of studies. But most of the dropout was because they did not have a primary care doctor in the system. And we needed to do that to have the passive ascertainment of the outcome of statin prescriptions because of the nature of the study. And I think that that's the key, because if you have that information, if you want it to be a pragmatic study where the investigators are not prescribing the medication, you need to have a clinician in the pathway. And I think I was telling you yesterday, the primary care doctors, like we gave a presentation and said, you know, this is great. Aren't you guys excited? And they were like, seriously, another quality improvement project? They were much less excited than we were. And they were like, you know, what's the disutility of taking the statins? And I was like, so it's just a different, because they have other obligations. So I think that that is the rate limiting factors, like who's the clinician? Because a lot of these patients, again, are more at the primary care level as opposed to the cardiology level. And even engaging our radiology team, right? Like we say, can you just, like, it would be a different conversation if we just said, can you just put this in the report? Which we thought about and have it move down to the impression saying, and the impression can say the next steps. Now, the issues with that is also like, who's responsible for that? And you know, that created some issues. And also we want to study it, because what if then everybody just gets a cath? That's not the intended outcome either. So we need to study that downstream healthcare utilization as well.
So we'll try and take audio from Dr. Chang, who I'll ask to unmute himself. And then I will. Dr. Chang, you want to unmute yourself and ask your question? Or I can ask it. All right, well, this question was, would you ever recommend aspirin in addition to a statin in any conditions?
Good question. And my clinical practice, again, this is not based on randomized control data. It's based on very strong epidemiological data, is that I start aspirin on anybody with a calcium above 300. That's I treat like as secondary prevention. The algorithm, I think it's very good at the binary task of even 100 or, you know, different categories, but I'm not sure how much I would trust it to be exactly precise, even though, again, it's the gold standard was a gated chest CT scan. So no, I wouldn't. I think that the safety concerns down of aspirin versus statins to me, especially when there's so much heterogeneity on the number of the CAC score, you know, but you could imagine a time where the algorithm is so accurate, it's essentially the same as a gated scan, where people can make those decisions. But even now with a gated scan, there is no RCT level evidence to say start aspirin, but that is what I do in my practice. Do you do that, Eugene, as well?
For treatment?
Yeah.
So, well, I mean, we haven't really done this with the AI, if they're calcium for about 100,
Yeah, and if they're above 100 and they have a high lipoprotein A, so I mean, in preventive cardiology is a combination of these risk enhancing factors. I certainly start aspirin and their risk of bleeding is low. But yeah, I don't think for this technology, it's ready for that decision. Hey, good to see you.
Thank you very much for the talk. Out of curiosity, I wonder, do you know what was the baseline statin prescription rates among those incidentally found significant coronary calcium?
Yeah, so we looked at that in our everybody heard the question. So in our observational study, we found that very few of these patients were, again, even though they had very high PC, so whoever asked that online, like 20% or so was their estimated risk of ASCVD. Very, very few were actually on statins.
Mm-hmm. And then I had a follow-up to that from an implementation standpoint. You know, you mentioned the EHR in prevention, right? You know, and how do we do that in a way that is, you know, that can be sustainable for the long term for both from the patient perspective and also from the provider perspective. You know, how can we incorporate the EHR system and use AI in a way that is in a way that is both you know, that is accurate and, you know, useful and doesn't cause too much.
Yeah, that's gonna be a balance as not only for, I would just say not even for the clinician and patient, but even for us as just like part of the workforce, right? There's a lot of these AI tools that are meant to help us write our notes more efficiently, blah, blah, blah. So I think some of these are, in theory, seem good ideas, but I think again, they have to be tested to see what is the benefit. For the AI with the EHR systems, I mean, I think there's some clear, if we know that these random notifications, they've done all these studies of put your patient on the statin, they just don't work, or they don't work in a sustained way in terms of adherence. So my answer to why we have such low statin rates for patients, even with ASCVD, is that the solutions need to be tailored to that specific patient, to that specific system. And that's maybe something that AI can help us with, like, what's the right solution of the many, many choices or the combination that would work for that patient.
So I want to push on your research findings with another question here. So if you take a step back and think about what real success would look like, if you implemented your intervention more broadly, eventually it should stop happening, right? Like what you're detecting is that we fail these patients. And so can you imagine, or how do you think about interventions that would essentially identify these patients early enough that every time we look at or incidentally obtain a CT scan, they're already.
Yeah, I mean, I think this is, Stanford is no different from any health system in terms of the low use of statins, even when they have atherosclerotic disease, even when they have known coronary disease. I mean, we're doing a whole study on that. Like, we're like, that can't be right. Like, really, they're not on statins in our healthcare system, in our clinics, and it's true. So yeah, we would win by not needing this, not needing this intervention at all, right? But these patients are just taking the statins, and again, a medication like statins you have to take all the time. There's also not just are you prescribed the statin, but are you adherent to the statin, and is your LDL low, and do you reduce it? So it's like all these downstream pathways. If I said I just want to implement this in the healthcare system, it would actually be a lot easier than to study it. But I think it has to be studied because there are downstream consequences that we haven't fully described yet.
Hi, very terrific presentation. Thank you for sharing your data. I have a very, very naive question. I'm not a clinician, but I was wondering if if I'm a patient and I came out positive after your screening, and I don't have a primary care doctor.
Yeah.
Can I use this type of result to go and say, hey, this came out kind of weird, I need a follow-up. Can I have a discount or something like that? My access to like, I don't know.
Yeah. That's a great question. And again, if ideally we could also test, like, what is the intervention that's working? Is it notifying the clinician? Is it notifying the patient? Is it the combination of both? And I would love to just notify the patient only, give them the information. And for our next set of studies, we've translated the document to many, many languages, 10 languages. We're going to make sure the readability is appropriate. The problem with that study is how do we ascertain the outcome, which is, again, statin initiation rates. And again, for IRB, we have a waiver of consent because we don't want, if you tell we're going to be watching your behavior based on AI algorithm around, it's going to prime their, so we don't want to, contaminate the study. But yes, and I was a part of this project baseline study that Stanford did with Duke. And we did, as part of just the protocols, we did a lot of these things. We did calcium scans. And yes, a lot of the return of results to study participants, they took to their primary care doctor and changed their behavior. So of course, that just happens with the return of any results, but it's very hard to study in a system where people get care at different places. And I do worry about the patients that don't have care in our system. That's why I think the pathway should be like, if you don't have a primary care doctor, we actually have a cardiometabolic health clinic that you could just like go to, and we're happy to prescribe you the statin.
Great. We'll end it there. Thank you so much. Well,
Thank you.